get this jam session started. And Karen, if we can go on to the next slide. We have had a lot of discussion of crisis services overall, and the Samhsa national guidelines talk about crisis being defined by the individual. So we're seeing an increased scope for what 988 is defined to target from Congress. But historically, crisis services are constantly attending to suicidal crises, mental health, substance use, and IDD. It's a smaller percentage of the overall cases, but they are high valence in terms of the challenge and needs and resources and coordination. So really excited to have Mary Sowers here today with the National Association of State Directors of Developmental Disability Services to begin to put that lens to the work that we're doing. And we'll get to that featured presentation here in just a few minutes. Karen, if we can go on. Margie, you wanted to make Paul feel good today, so you thought Game of Thrones means.
Yeah, I know Paul likes Game of Thrones. So just a reminder that 988 is coming. We have less than a year. And, we talk about how we want a whole system like 911. So that's more than the phone number. So now is the time, I think, for it to be, in your own communities, be bugging your state legislators and try to find out what's going on, because TikTok, it's less than a year.
And Margie, the thing that resonated for me about this is you keep coming back to this. It's a simple metaphor, but I think it's the right one, is that if we have 988 and no mobile, it's like 911 without ambulances. And if we have ambulances, but no readily accessible to everyone hospital emergency departments, it also would not work if we didn't have the kind of facility that you operate in Tucson.
Yep, it's a whole system.
And Margie, of course, the other thing about Game of Thrones is, we had 7-8 seasons of people battling each other, and they finally realized, no, we ought to come together for this bigger challenge, and that's what happened.
Yep.
Well, and the other thing that applies to this, David, is the saying the lone wolf dies, but the pack survives.
The pack survives. Dr. McKeon gets us kicked off with Game of Thrones. Thank you, Margie. Let's keep going here. That might be the quote for next week. So we continue to expand our national organizations. Karen, do you recall we just added 2 more? Access OS, I think, was one of them. Do you remember what the other one was?
I think it was the National Federation of Families.
Yes, great. And speaking of that, we need a featured presentation, and maybe the National Federation and NAMI and others, we could be thinking about these issues related to family and crisis services. We have not spent enough time in the Crisis Jam on those issues, but welcome to all of you. If you're a national organization and not listed, and we have many local organizations that are also not represented here. Continue to hold at 10 states of Medicaid, but we have added 2 more countries. Had a lot of engagement from the UK recently, and we'll have a featured presentation from the Netherlands and a crisis talk interview with Stephanie Hepburn coming up. So Karen, we did update our record, still is that 272 participants. Hope to break through that on September 15th with our special edition overlap with the NASDDDS annual meeting, but also have now the Netherlands with that featured presentation coming up. So next slide. Continue to post all of these. We have 20 of these meetings now in full video with the text chat transcript connected to it. And if you click on that button in the upper right, you can get to all the memes from Margie, the quotes, the tools, the presentations, et cetera. So we'll continue to put all that information up. And we're also, we'll be having a featured presentation on deaf and hard of hearing services as it relates to crisis care coming up from Steve Hammerdinger in a couple of weeks. And we'll be bringing in interpreter and transcript capabilities to this meeting. So be patient with us. We're going to get that up and going ASAP and have that capability as we hopefully model out the direction that we're all going. Next slide, Karen. And again, really appreciate Karen and Ren and the team professionalizing. You should be getting a more routine and not as frustrating the frustration with Outlook and its multiple invites. We're getting to a cleaner approach with the constant contact, and you should be getting a regular streamlined newsletter that we'll be getting out soon. Great. Oh, so today's quote actually comes from Stephanie Hepburn's crisis talk this week with Kristen Nalen. And this quote, I thought, is just really, this isn't rocket science. This is straightforward stuff. But Kristen talks in the article about mobile crisis teams only being called a few times. You count them on one hand, the number of times in a year that mobile teams were being called by first responders. And so county leaders and EMS came together, and it was just, they took too long to respond. So don't hurry, be happy is actually not what we're trying to achieve here. Speed, the speed of answer for someone reaching out for help, the speed of the mobile team to be on the scene is what makes law enforcement say, hey, that's a viable alternative. The speed with which someone can get into a overnight care, and Margie, if folks are interested in more on that speed, you've done a host of work in publishing metrics and Lean Six Sigma around door to dock time. Margie, say a word or two about the importance of actually hurrying is an important element here.
Yeah, I mean, because it's an emergency, so people need treatment. And similar to what has been shown in the emergency medicine field, the earlier you start that treatment, earlier start that evaluation and intervention, then the better your outcomes are going to be. And so within our facilities, we looked at that, and as we decreased our door-to-doctor time to something around, less than 90 minutes, more closer to like an hour, we saw decreases in injuries, assaults, seclusion restraints, increases in the numbers of people that we were able to get discharged in that 23-hour period. So the earlier, the better.
Well, I mean, and that's why 911 pushed forward with fire, right? Because the loss of life, the property damage, the seconds made a difference, and they make a difference here too. So, Stephanie, actually, let's get into it with Krista now. This fascinating article, as you leaned into the technical innovation sparked in large part by the COVID pandemic, and this great article with the NASDDDS Beyond Bed series.
So, as you mentioned, I chatted with Kristen Nalen. Hopefully she's on the line. She's the Senior Project Associate at NRI. And in the article, she shared some of the technologies that facilitate and enhance crisis care services, but she goes into how exactly like what you said, how the COVID pandemic really pushed people outside of their comfort zone, lessened, regulations. And, she talks about, honestly, a reluctance sometimes among behavioral health providers at the beginning to jump into telehealth, but in the end, it seems like people have liked it, and it's allowed them to get in touch with people who they ordinarily wouldn't have been able to reach. And she talks about, as you mentioned, the struggle in Charleston County, and that's exactly right. It was just, I think they were calling, and it wasn't just, this was a cumulative number both from law enforcement and EMS, and it was a total of 5 times per year. And hopefully Kristen can go a little bit into this example, but the outcome now, they integrated telehealth, EMS carries tablets to pull in mobile crisis. And I think it's moved from 5 times a year to 85 times a month in terms of their outreach to mobile crisis. That's a massive jump. Kristen, if you're on the line, maybe you could talk a little bit about that and some of the innovations that you've seen grow during the pandemic.
Sure, absolutely. Thank you both for having me on today. So Charleston County realized that they were having a problem. Their mobile crisis teams weren't getting phone calls. They sat down with EMS and tried to figure out why, and it was just so much easier for EMS to drop people off at the ED than actually call the mobile crisis team and wait 2 hours for them to respond. So they brainstormed and they figured out a way to get technology in the hands of EMS response. So in the field, the ambulance team will evaluate someone to see if they have a medical or psychiatric emergency. And if it's determined that they have a psychiatric emergency, they call their leadership, who arrives in an SUV, and that person has an iPad with them, and they connect immediately with the mobile crisis response team, who can help triage a situation. And most times they're able to de-escalate the crisis in the field and set people up for follow-up care. Other times they're able to direct people to more intensive settings to help manage their crises. But yeah, as you said, Stephanie, 5 times per year, which I got wrong in my paper because I just couldn't believe it the first time I wrote it, to 85 times a month. And after implementing this program, they've seen a 58% decrease in ER use for individuals experiencing a psychiatric emergency. So David, as you said, programs like this, we have to have the ambulances, right? We have to have the response teams, and programs like this can really help people with implementing 988. I think especially too with the workforce shortages we're experiencing related to COVID and compounding the workforce shortages we already had in the behavioral health field. So,
Kristen, some people really have trouble getting their arms around that there's actually a cost advantage of these crisis services.
Mm-hmm.
And in my experience, it's actually a profound one. And it comes from very simple math that you just described. You said most of these cases are resolved in the field. But if you don't have that in place and they go to the emergency department instead, it just stacks up. So talk just a little bit more about that, because the cost implications of this, it costs more to empower teams to go out into the field. But the overall net savings of not having these days-long ED stays, this is profound.
Absolutely. And I wish I had some figures for you right here, but you're right. There is definitely a cost savings because we're saving people trips to the ER. We're not boarding people there. I know that you also interviewed someone from Grand Lake Mental Health Center in Oklahoma, and they were able to reinvest funds that they would primarily use for inpatient settings to equip people with iPads in the field, and they're finding significant cost savings with that as well. So yes, it's beneficial all around. It's better care for people. It's cost savings for the system. So it's a win-win situation for everybody.
Stephanie, were there any other technology innovations that stood out to you as you did this interview with Kristen?
Well, I think there were numerous ones, but I think what really got me was toward the end of our conversation, Kristen mentioned, during the summer, she's interviewed a lot of behavioral health providers, and she was just really struck by the fact that the majority had never heard of 988. And that was something, and she was talking about how, social media and also other technology platforms could be utilized to reach out to behavioral health providers as we ramp up and allow them to be part of the conversation. And she said the same is true for consumers, that, there's this huge, massive change on the horizon, and just having an awareness would allow people to come to the table and allow the system to be different than what it is now, to really focus on parity by having those folks at the table.
Kristen, anything else from the article that you wrote for NASDDDDS that you'd like to leave us with?
I think that pretty much covers it. I think that, one of the other things that stood out, as Stephanie just mentioned, is, there's a lack of marketing of crisis services, and we can't help people if they don't know to reach out for help. And I think, it might be a little premature to start marketing 988 to everybody in the field so they don't call and expect services right away. But making sure the word's out there, bringing diverse populations to the table to ensure it's an equitable system and that there's trust in the system, I think is critical to its success.
Terrific. Kristen, thanks so much for joining us, and we hope you'll be back.
Thanks so much for having me.
Great.
Thanks.
Next slide, Karen. So Dr. Everett, are you with us to tee up some updates from Samhsa?
Yes, sir, I am. Thank you very much. Yep. So I think last week you met some of our new staff, a new communications director, Kate Galantis, and then we have a new project manager, Rebecca Zornick. So we're very glad to have that this visibility that our team is growing at Samhsa. Doing our regular sort of federal thing, when much of our energy these days has been focused on securing funding moving forward, and that's sort of what we've been doing. We have received a request from the Disaster Distress Helpline about expanding the services for deaf and hard of hearing populations, which are really important. They've got some new visual technology that they want to use, which will help, and hopefully also applies to the more traditional 988, not just disaster related, in other words, but the broader suicide prevention and mental health crisis line. We have a couple meetings going on. So this Friday is ISMIC, the Interdepartmental Serious Mental Illness Coordinating Committee, which is I'm bringing up here because one of the ISMIC is a federal advisory committee that was set up as a result of the 21st Century Cures Act, which passed in 2016. And it was required to create 2 reports. The first report was submitted to Congress in 2017, early 18, and included in it, it was called The Way Forward, and included in it a very strong recommendation that access be improved. In other words, that was one of the main problems that people with SMI and the stakeholders and families that are involved in the SMI and also SED, serious emotional disturbance in children, identified as a problem is access. And so we all know, this community knows that 988 and related services is an important part of a way to achieve access. So, these big policy things require oftentimes a lot of little or a lot of components to get them to sort of rise to the level that 988 has risen for us. And I think ethnic gets some of the credit for sustaining some of the work that undergirds where we are right now with the whole 988 thing. That's a public meeting, so anyone that's interested is invited to listen in to that meeting. So there's that. We also are having convenings that are more along the lines of a policy academy next week. Policy academies are pretty much by invitation only, so they're not really available to listen in on per se, but what this community probably would be interested in is they're very focused on Medicaid, Medicaid, and the behavioral health authorities in the states that are in region 2 and 3, which is the mid-Atlantic. And focusing on in the style of a policy academy, which means the various partners that have to do with funding and also with delivery of services and oversight of the delivery of services will be meeting together to come up with plans at the state level. If this is effective and it works well, the concept would be to take this to other regions throughout the United States. These are 2 and 3 of the HHS regions. Otherwise, I think we're prepared. Tison has some information for you on the block grant. I'm not sure if you want to do that now, David, or if that's a special feature. And then I think Richard has a few things to report out on.
No, it'd be great, Anita, to go ahead and do the mental health block grant update.
Tison Thomas is our division director. He's a longstanding Samhsa employee who's is our go-to person in our block grant. And just by way of review, I think everyone's familiar. The block grant is distributed to all states by a formula based on population and also based on prevalence of serious mental illnesses. And the block grant has received a lot of attention, which we've welcomed recently. Its budget has been virtually doubled as a result of COVID and other sorts of things. And one of the, well, I'll let Tison tell you about I saw Tison a minute ago. Tison, are you there?
Yeah, I'm here. Okay, thank you, Dr. Everett. And as Dr. Everett mentioned, Samhsa's mental health block grant is a formula grant program that goes to all the 50 states and territories to address the mental health needs of adults and children. Like Dr. Everett mentioned, the funding is very flexible, and states can use the funds based on their needs and the gaps in the mental health system. For last several years, Congress also used the mental health block grant as a vehicle to implement specific programs or initiatives. So during this current fiscal year, through 3 different appropriations, Samhsa released approximately $3.2 billion to the states. Through the regular mental health block grant appropriation and the COVID relief supplemental funding to the block grant, Samhsa required states to set aside a minimum of $75 million to address crisis services. While crisis services historically could be supported with block grant funds, the new funding or the new set aside must be used for crisis services only. The block grant crisis services set aside reflects a growing awareness of the crucial role of crisis services in providing the right support in the right place when people need it most. The block grant set aside must be used by states based on the statutory language. The statutory language requires states to use the mental health block grant set aside to a set of core crisis care elements, including centrally deployed 24/7 mobile crisis units, short-term crisis stabilization beds, evidence-based protocols for delivering services to individuals with suicide risk, and regional or statewide crisis call centers coordinating in real time. As I think we mentioned this many times, that Samhsa, together with the NASDDDS, also released the national guidelines for behavioral health care, the best practices toolkit, along with 9 other white papers that assist states and communities in implementing crisis services. These resources are available on Samhsa as well as NASDDDS website. Samhsa envisions that states provide a comprehensive crisis care system, which not only include someone to talk to during a crisis, but having a team of mental health professionals available 24/7 to be deployed to help those individuals in crisis, and a place to go if the person needs emergency care, ideally a crisis stabilization program. So the block grant funds are especially useful because they can be used flexibly to build the crisis infrastructure or to help pay for crisis care for people who are not Medicaid eligible, or to initiate or start up a new crisis program that can then be picked up by Medicaid. The block grant funds are also useful for startup efforts, mobile crisis teams or crisis stabilization or crisis residential programs. Also, block grant funds, one of the stipulations is that it cannot be used to supplant or replace prior state funding for existing services. But in building a comprehensive crisis system, states must leverage and shape Medicaid to become the key payer for crisis services, especially for mobile crisis teams and crisis stabilization programs. And that's something which we work with state on a regular basis. By having a set aside for crisis services within the mental health block grant for states, Samhsa also envisions that the crisis services, however effective in mediating crisis, must be part of a larger continuum of care that supports individuals in their recovery and efforts to lead successful lives in the community. So building a robust crisis continuum without the foundation of an equally robust community-based service array will only shift a repeated use of emergency room 988 or 911 or inpatient hospital services and repeated use of crisis services. So every state and territory are required to submit a proposal to Samhsa on how they will expend the mental health block grant set aside funds that Samhsa issued this year. So all the states submitted them. For many states, they are on their initial planning stages or on implementing the required set aside services. From Samhsa's perspective, we want to ensure that the state for their crisis continuum focus on the 3 basic elements of the crisis system this year. So it's basically someone to talk to, someone to respond, and then a place to go. So Samhsa, through the block grant, will monitor the implementation of crisis services by looking at the 5 different stages of implementation for which each of these 3 basic elements, someone to talk to, someone to respond, and a place to go. So the 5 implementation stages include an exploration stage. This is where they're exploring on a particular one of those particular elements. The installation stage, then an initial implementation stage, then a full implementation stage, and then we look at program sustainability over years. So these are the 5 different stages we are looking at when state starts implementing the crisis services programs. So based on the above, states this time around reported to Samhsa that 42 of the states have their entire state's population can access a call center in their state during a crisis. These call centers may or may not be connected to the National Suicide Prevention Lifeline, but they are within the state or a county or a city have access to, their population have access to a call center. 18 states reported to Samhsa that they have a 24/7 mobile crisis team that can be deployed anywhere in the state. And that may or may not have a children's component to it, but they told us that they have a 24/7 mobile crisis team that is across the state. And 10 of the states reported that they have their entire state have access to a crisis stabilization or a crisis residential program that covers their entire geographical area. So we'll continue to work with states in assisting them in implementing the crisis services, including the 988 implementation. We welcome any technical assistance requirement from states. Let me stop here. I know that I talked too much.
Yeah, no, Tisa, this is all terrific. So there's some questions in the chat that I want to make sure we get to. The initial set aside was a 5%, but 75 million sounds like double where we started. So I'm not sure, Angela's referencing that the 10% has not been formally approved yet. So where are we in 5% to 10%? And where are we in relationship to this being recurring year to year?
Right. So the initial 5% set aside is for the $757 million. That was the regular appropriation. And then we also issued states a supplemental funding of $825 million, which is called the COVID relief supplement to the block grant. And we required states to have a 5% set aside in that particular supplement as well. So combining the 35 million initial investment along with the COVID relief supplement, it's around $75 million. But we also told states that it's not just those 75 million they can use. They can use the entire mental health block grant if they want to for crisis services. But it's up to the states to make that determination. But many states have using more than the minimum required set aside. I know that states are using it for other purposes, including crisis continuum, also working with the 988 or implementing 988 in their core centers. So they are using it beyond the 5% set aside for sure.
Terrific. Love. So we're talking about a foundation that's just simply unprecedented to build out this capacity. And Tisa, your encouragement to then leverage Medicaid to go all the way through the finish line on this. Just terrific. Dr. Everett also referenced ISMIC. And of course, ISMIC also, those original recommendations paved the way and actually called for the national guidelines for behavioral health crisis care that you referenced. So this is just terrific. Dr. McKeon, do you want to give an update and build on some of Dr. Everett's and Tisa's update?
Sure. Thank you, David. One thing I would want to emphasize that Tisa also referenced, but it's kind of flown a little bit under the radar, is that one of the approved uses of the crisis set aside by Congress was the development of protocols for people at high risk for suicide. And I think that's important in light of all the discussions we've had about the need for coordination between 988 and 911, and 911 being protocol driven. Also, it has the advantage of being the kind of thing where by making an investment in and establishing it, it's unlike, for example, a mobile team, which requires continued funding, that the establishment of a protocol would have costs up front that would not necessarily be year to year. So just an emphasis that is kind of the fourth thing that is identified in the congressional language and in Samhsa's guidance to the states that I think will be of increasing importance as we move forward to actual implementation. And then the other thing I would just mention in the interest of time is that there's really been, at least in my experience, there is now an unprecedented level of attention within the United States Department of Health and Human Services and with White House Domestic Policy Council and its Interdepartmental Policy Council on suicide prevention and on crisis care, trying to see how we can best all work together to maximize our impact. And it reminds me of a saying that Jerry Reed has often used, which is the importance in suicide prevention of our flying information, that we can do much more working together than working in opposite directions. And for those of you who may not know Jerry, Jerry has been part of every development in suicide prevention federally, going back to the 1990s when it really started with the first Surgeon General's call to action, the first national strategy. Jerry is retiring at the end of September. And David might want to invite Jerry to maybe perhaps share a few reflections on how far we've come as, as a thought for that. So anyway, that's what I have.
That's a terrific idea. And of course, Jerry, key in the development of the National Action Alliance, Richard, which was the vehicle for the Crisis Now policy platform. So that's a great idea. Dr. Everett, any final comments to wrap up the Samhsa update after Richard's and Thiessen's update?
Nope, that's it from us. Thank you.
Okay, great. Brian, do you want to give us an update for the part of the states?
Yeah, I'll go quickly because I think that Anita and her team's report, Thiessen and Richard, has been really good and very important to what the work that's going on in the states. It's very exciting. States are continuing to work on 988 and crisis services. And as Thiessen mentioned, the block grant and the supplemental funding has really helped push that forward. Also wanted to mention the information from Kristen and Stephanie regarding the use of technology. And I think this is real important because when we talk to the states, every conversation starts with workforce, 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 workforce. And the more we can use technology early on to divert people from higher level services, get people to the service level they need, the more we can improve efficiencies, the better it's going to be for the states and for state budgets. Let me also add that there are a couple of significant things that have happened recently. One is the FDA approval of the Pfizer vaccine. We're hoping that that will result in many more people getting vaccinated, and that will take a lot of the pressure off of the leadership in the states. Right now, almost any problem you can imagine regarding parenting, going back to school, et cetera, is falling on the laps of leadership within the states. And it's a very difficult time. So the more that we can get a public health position stabilized, the more helpful it is to state leadership. And let me just say that the return to school, we know that in some states, kids are already returning to school. And in some situations, they're returning to school and very quickly the kids are being sent home, kids in the elementary school age, because of a positive finding, and they have to go home in quarantine, which is very disruptive. So the school year hasn't really started yet in most states, but the anticipation is that it is going to be difficult. And so the more we can help parents, the more we can help teachers, help students, that actually works in the area of prevention and early intervention to decrease the risk of crisis. So wanted to just highlight those areas and also to just thank Samhsa for all the work that they've been doing. And thank you, David, too, you and your team.
Wow. Thank you, Brian. And look, for those of us who are provider organizations, you've got a number of us on the line. We are in a double crunch, right, Brian, that you referenced. It's workforce shortages in terms of hiring hundreds of roles that we have open to get hired, and then but also trying to get our workforce vaccinated. And increasingly, we're starting to review regulations that are coming down requiring vaccination of our staff. So we want to do both. We want everyone vaccinated, but not everyone is going to be vaccinated. And we want to fill all these roles. Here locally in Phoenix, Margie, we've got Banner Health. Banner, I think, has 60,000 employees. And I don't remember, Margie, do you know the deadline that staff had to get vaccinated?
I think it's October 1st. We are about to announce our requirement, and that will be November 1st.
You're going to do the same.
Yeah, I mean, I just researched all this because I had to write the communication that's going to go out. So, I mean, the AMA, the American Medical Association, American Nurses Association, the American Hospital Association, pretty much every single professional organization, including the APA, has all endorsed that healthcare organizations should require the vaccine, with of course, the legal exceptions for medical and religious exemptions. So, and the data is pretty clear that vaccination, even though with the Delta variant, vaccinated people can still transmit it, it's still less than unvaccinated people, and it's for a lot less time. Yeah. And then if you look at the data, and both nationwide, and of course I was looking in Arizona because that's where we're at. It's like 95% of all the hospitalizations are unvaccinated people, 99% of the deaths, that's Arizona data, but it's pretty similar nationwide. So when people look at like, is the vaccine quote effective, the outcome to look at is hospitalizations and death rather than infections, because it's even with the Delta variant, it's pretty clear that the vaccines prevent those bad outcomes.
And Margie, we're right there with you. And you personally have been tremendous in helping us move forward with our organization. We're closer. We made some big gains in vaccination. And yet we have 51% of our staff nationwide are people that are non-white. And those populations are much more cautious, have been more cautious. They're coming along, but this is sort of the challenge we're in. I did notice a note from Tia in the text chat about call centers staying remote. The call centers are staying remote. It's the mobile teams and the crisis receiving facilities where, Margie, your organization, our organization, we never stop seeing people throughout this crisis, including individuals who had symptoms of COVID, where we're having to attend to those concerns. So that's the challenge, is this face-to-face care of crisis. So Brian, great stuff. Let's go to the next slide, Karen. And Karen, we're going to fly through this next section. I didn't see Hallie in the list. Hallie, do you happen to be on for a quick note about the Taking the Call conference? If not, Karen, let's try to tee that up for next time. The next one, I do believe we have either Tony or Michael on the call to give us a quick couple of words about the upcoming Behavioral Emergencies Conference from AAEP. Michael or Tony, are you on?
If they're not, I can do it.
Yeah, go ahead, Margie.
Yeah, so because I'm on the board of this organization. So this is a really great conference. It's done every year, and it's the American Association for Emergency Psych. And it's a really cool organization. It's unique in that it's a mix of emergency medicine folks and psychiatry, mental health folks, because, as much as we're trying to build all this great crisis stuff, a lot of people with psych issues still end up in the ER, and they need, to have care there. And so this conference, it's really pragmatic too, because all of us who work in any sort of emergency thing, we all kind of have our touch of our own ADHD. So it's not like a series of hour-long PowerPoint presentations. They've really done a great job in having it be really interactive and lots of short focused stuff. And pretty much everyone's all in the same room for the 2 days. And so, it really is a great, as far as like a clinically useful conference, it's really great, not just for physicians, but anyone who's kind of involved in this work, I think will get something out of it.
Great.
And pretty much it's every year, and it alternates between Vegas and Phoenix.
Oh, there's Jack. Jack, sorry, I should have called on you as well. Thank you. Jack, you want to say a quick word?
Sure. Completely biased. I'm a past president of the association, but I happen to think it's a great group. It is one of my favorite meetings. It's a nice, highly concentrated couple days of a diverse, eclectic group of folks who are really passionate about behavioral emergencies and trying to get it better. The mission of our organization is to advance evidence-based compassionate care for people with behavioral emergencies through research, education, and interdisciplinary collaboration. And our meeting, it's sort of the highlight of what we get to do. And fingers crossed, throw salt, whatever other rituals needed, we will be in person in Vegas and safe in December. So.
Terrific. Thanks, Jack. Karen, let's fly through these next slides. We want to get to Mary, and I had intended to sort of tee up Matthew Goldman. We're going to be looking at a new segment, the Research Corner, and there was this really key article from Kaiser around the pandemic's impact on Black and Brown communities, but we'll pause on that till next time, given our time. We're also going to skip Sarah. Sarah doesn't have a lot of updates today, so we'll skip that one. And I had hoped to have a weekly update of adding a new state. So next slide, Karen, we had this great slide from Washington State and are now working with Nevada and Virginia and Utah and some others on getting, and Oregon on getting a similar slide to follow, but we'll wait on that till next time as well. So Mary, Brian, do you want to give a quick introduction for Mary before we get into the featured presentation today?
Yeah, just real quickly, Mary is terrific. I've known her since we worked together in Maryland. She's the chief executive of the national organization, NASDDDS, and she will give more background on that. She's somebody that's the go-to person for us when we have questions about IDD. She's a terrific leader, a nice person. Glad to introduce her.
Hey, Mary, welcome. Thanks for being here.
Thank you so much. And thank you, Brian, for those nice words. It's wonderful to be here. I'd love to congratulate you on this whole forum. It's just a wonderful way to share information. And we're very honored to be invited to speak to you today. David, I think as you teed up the conversation, you mentioned the importance of ensuring that crisis services really cover the breadth of individuals that can be, that will need them at any point in time. And so I wanted to spend just a little bit of time talking about our association, our members' challenges supporting individuals who have IDD, but also have mental health support needs, and just some of the stymieing issues that we've experienced as we've tried to help states navigate and build systems of support that really meet people's needs. Next slide, please. So as Brian alluded to, our association is a bit like the sister association in NASDDDS. It's the 50 states in the District of Columbia. Each state has an administration that supports individuals with intellectual and developmental disabilities, oftentimes lifelong. So supporting people from very young childhood to death. Our members oversee about 1/3 of the nation's Medicaid long-term services and supports budget. So our members do provide home and community-based services and a decreasing footprint for institutional services, but really aim to provide opportunity for individuals with all support needs to be able to have a good life in their communities. Next slide. So an estimated 7.4 million people have an intellectual and developmental disability in the United States. Our prevalence information is like other disabilities, a little bit challenging, but that's a pretty sound estimate. And there's really an expectation that of those, between 30 and 70%, depending on the studies that you might cite, also have a mental health condition. And despite these high levels of prevalence, there's really a chronic lack of a whole person approach in most states to support individuals with co-occurring IDD and mental health. We recognize not only the importance of having good clinical capacity to support individuals, but also those follow-along supports that really enable the individual to live successfully within the community. Next slide. So, some of the longstanding barriers, and I probably should have reframed this to sort of opportunities for improvement, because I'm feeling, we've certainly got a lot of opportunities to improve. And as I think a number of the speakers prior to myself noted, we are at a pivotal point in history where hopefully we can take advantage of some of these opportunities to really change the trajectory of supports and services in the country across the board. But as you know, for folks that work within states or do business within states, you know that sometimes there are these pervasive structural silos, which sometimes prevent folks from communicating effectively with one another or really taking a whole person approach. We've got the workforce issues already discussed are pervasive in our service delivery systems writ large. But we also have a clinical capacity shortage with individuals who are experienced or willing or have the supports necessary to support individuals with intellectual and developmental disabilities who might communicate differently, who might take some additional time. And importantly, we're increasingly learning about the just the essential nature of ensuring trauma-informed care for individuals with intellectual and developmental disabilities across the board. In addition to some of the clinical shortages, we also recognize that there's an important component, hopefully, in order to stave off future crises or hopefully to prevent crises from beginning, but really supporting the direct support professionals and families to really have the skills they need to really be effective partners in helping individuals through difficult challenges. And then we also have, as you might know, we've got a lot of anachronisms in our funding stream. So in our systems, many of the individuals with IDD who are supported by our members are Medicaid eligible, and there are some really long-standing, and they've been somewhat ameliorated, but they still exist, anachronisms within Medicaid that persist, oftentimes based on misperceptions that individuals with IDD can't benefit from mental health treatment. And so I think there's a growing recognition that that is not true, yet these vestiges are sometimes hard to shake. And all of these facets can really impact a state approach to how they respond to crisis services. Next slide. So some of the keys, and we've worked with both our partners at NASDDDS and at the National Association for Dual Diagnosis on trying to pull some states together to identify strong practices and really sort of synthesize some of the key components, making sure that you've got state organizational structures, financing, payment approaches, and policies that transcend some of the stovepipes that have really hindered our progress so far. Trying to build up that access to clinical capacity and not losing sight of the importance of supporting the direct support professional workforce, who for many of the folks that our members support are essential in that ongoing community integration. And then really identifying and designing perhaps additional effective service modalities to really support individuals with IDD. Next slide. And then, you know, some of the things that happen that are less than optimal for folks with IDD. And I should have started the conversation by saying I was going to say not a week, but I don't think a day goes by when we're not hearing from our members that these are the issues that challenge the system more than any other. They are certainly just individuals are in crisis, and there's often not a strong response approach that one system can handle by themselves. But so all these, certainly we see some outcomes that are less than ideal. We see an over-reliance sometimes on pharmacology and psychotropic medications in our, for individuals supported when there might not be a medical indication for those. We see folks becoming sort of stuck between two systems, sometimes literally in an acute care hospital setting where the systems really can't figure out a solution. And importantly, we also see labels affixed to individuals with IDD that are difficult to shake, and those wind up carrying through and you know, sort of sometimes changing the services and supports and how individuals perceive them really for their whole life. And so all of these things wind up kind of doubling down on a less than ideal situation for folks who have a dual diagnosis there. Next slide. And so this, you know, I think there's a lot of reason for optimism right now. We just had a few meetings in the past few weeks that have really, I think, buoyed our spirits in that we're in a really optimal time, in addition to unprecedented and historic investments and attention to the building of infrastructure around home and community-based services writ large. We are seeing this opportunity for partnership and collaboration with our partners in Medicaid, mental health, child welfare, and others to really change a trajectory, to really devise some better cross-system collaboration, to try to enhance the availability of clinical capacity. And really, one of the things we're working on with our members is really bolstering that opportunity to be good system partners, to sort of take the jargon out of our communication with one another and really try to speak language that all of us can understand. We're seeing the importance of prevention and early intervention to try to stave off some of the most significant crises. Really a focus on individual and family-centered focus to make sure that folks can also be really active participants in their own preventive strategies and solutions. And then thinking about crisis services as a continuum, both some from the early to how to stave off, but also recognizing that when folks are out of crisis, it's really important to have the necessary supports and services around them to help them maintain a successful approach. So again, I think all of the conversation preceding mine today has given me great hope that this is a nice space and time for us to really engage deeply in these discussions and devise a strategy where our systems can very much communicate and support one another in the common goal of helping people through these crises. Next slide. And then, you know, I think the states, we're a bit of a bell curve. We've got states who are really leading out on some really great strategies. I think any state you'd ask would say they've got more work to do, and so no one's got it fixed entirely. But I think those aspects that have been common across those are a reflective system analysis. So really making sure that there's continuous quality improvement built into the strategies that are in play, a commitment both at leadership all the way down to collaboration and problem solving across and within agencies, making sure that there's a multi-system intervention approach so that there's a not falling to one entity to solve all problems, but instead really pulling in all the resources that might be available and the best ones to meet the needs, and really that commitment to person-centered and person and family-centered practices. Next slide. And then just a few states shout out to, and I know a couple of my colleagues from these states are on the line here, but we've got some very good promising practices in Michigan where a system is structured and you've got expertise really baked into the service delivery system with a familiarity with IDD and mental health support. Pennsylvania's got an investment, which is a shared investment from the IDD system and the mental health system for Capacity Building Institute that really takes into account not just sort of the clinical capacity, but ensuring that all members of the service delivery system have a seat at the table to understand and really bolster their skills. We've got Missouri, who's established an alliance for dual diagnosis and is using ECHO to try to devise some widespread support opportunities. And similarly, Ohio's developed a joint effort around trauma-informed care and also utilizing the Project ECHO. And then Washington State has an HCBS program that's really aimed at supporting folks who have some of those challenging pieces. While it's not only for individuals with mental health support needs, it certainly is for those folks that might come with reputations or have labels and really wrapping around a whole system of support around those. So I've just sped through those, but again, I think there's a great opportunity for all of us to come together and devise some crisis services that can meet the needs of all the individuals. And I think I've got one more slide. But essentially, you know, just as we embark on some of these efforts, making sure that that there's a real attention in crisis services to a responsiveness for all individuals, regardless of disability, race, ethnicity, spoken language, and alternative communication, ensuring those strong partnerships, and making sure that the post-crisis is not an afterthought, that you really have those supports and services that can follow along and hopefully continue to support the person after the acute situation has resolved. And again, I think language can sometimes be our biggest impediment. We all have system speak, and sometimes it creates misunderstandings or just an inability to come together. And so I think while it sounds so very simple, it's really a critical component to start to build a system of support that's going to meet everyone where they are. And then also sort of building in strategies to leverage the expertise. Certainly a crisis call center and the response teams can't possibly carry all the expertise they need in their back pocket. And so making sure that there are those resources that are readily available to folks to support them in those times when the needs arise. So we're really thrilled. I will be regular, you know, we're first-time callers today, but regular listeners on the Crisis Jam from here on out, because this is just a wonderful opportunity, and hopefully we can be an active participant as you all shape the crisis supports across the country. So David, thank you very much. Brian, thank you for this opportunity. And
Mary, we're so glad you're here. Pronounce your acronym for me.
Yes, we call it NASDDDS. It's the National Association of State Directors of Developmental Disability Services.
I just need the NASDDDS. I think I got it now. So having NASDDDD and NASDDDS here with us more along with NASBD, I think Brian and Samhsa, and we're all really excited about your integration and connection here. So you referenced Project ECHO with a couple of the states that are sort of exemplars. Mary, either you or maybe, I don't know if you've eyed from the chat or from the list of people who are here, someone from one of those exemplar states that you might call out for us to get a little bit on Project ECHO.
So I'm not sure if we've got anyone from Missouri or Ohio here who we sort of noted, you know, shouted out directly, but I did see Deb Pinels on the line, who I'm not sure that Michigan is using Project ECHO, but certainly they're using many strategies to sort of break down these silos. So I don't know if Deb, if you wanted to say a few words. Yeah, let's get a comment from Deb.
Well, hey guys, thank you. First of all, nice to see you, and great talk, Mary. I think you're bringing home just the points that we need. You know, in Michigan, we have a combined behavioral health and developmental disabilities and substance use service, which is interesting. So as we're rolling out our crisis services and looking at 988, it's already baked in that we're going to need to think about the three populations. And we don't have an ECHO for this population, but there is discussion. We take advantage of our work with our Developmental Disabilities Institute, and we have a LEND program, which I think all states have, the Leadership Enhancement for Neurodevelopmental Disabilities, which trains a variety of professionals to work with people with IDD. And I think those are some of the strategies that we need to think about in terms of building a workforce, and then having available the knowledge base, because not every crisis center will have an expert in this area.
Right.
And so where do we go for help when we need it, whether it's through an ECHO model or some other way of, phone a friend model.
Yeah, Deb, thank you so much. There's a note in here from Colorado about and again, we're talking about this expertise. Debbie Atkins is on with us, a crisis guru from Georgia. And Debbie, in the perfect world, we'd have dedicated special teams for both behavioral health and then separate for IDD. And Georgia did have that for many years, and just decided from a practicality, Georgia ended up blending those under its Department of Behavioral Health and Developmental Disability Services into a single set of statewide mobile resources. Can you talk a little bit about the benefits of that and the challenges of that and how that's worked?
Sure. So for Georgia, the whole crisis continuum. So our GCAL, someone to call, someone to go through our mobile crisis, and then we're branching into our somewhere to go with our crisis stabilization units, adding in a dual diagnosis component. So GCAL has always had a component of answering for any type of disability. And so IDD has always been a part of that. We did blend our mobile crisis. We do require that they have access to BCBAs, RBTs. The community doesn't really know what a behavior is stemming from. Is it psychosis? Is it their intellectual disability? So we have to have those expertise, right? So it's really training our staff to go out and help discern that. And we found that it has been very effective. Of course, getting enough individuals who are trained and with the right certifications is always difficult. We do allow our BCBAs through telehealth to add support to the team on the ground, just because there's no way we can get enough in Georgia. We've started a pilot just recently. It opened in late June, where we have our crisis stabilization units that have a 6-bed pod for dual diagnosis. It's staffed with BCBAs, RBTs, behavioral health. They still have access to all the doctors and nurses, but it's a pilot for us to look at how can we in our crisis system accommodate someone who might need both. They're going to have some behavioral challenges, but they also need some medication challenges. So for us, it's really the staffing, making sure that, we have the funding and the blending protocols through, our DBHDD has the whole vision, right? So we have IDD and behavioral health. So we're really looking at policies, looking at protocols, procedures on how we make sure crisis is open to all of our services, all of our individuals.
Terrific, Debbie. And just as I'm hearing you speak, Debbie, it's reminding me for a future presentation that individuals with all of these various challenges, we've also got very significant chronic medical disorders that are going to be across the populations that we're serving. We really haven't attended to that much in these meetings. So, hey, final thing, Mary, I know your team, Barbara Brent, is also with us. Do we want Barbara to make a quick comment?
Sure. Barb?
A lot of buttons to click here. Sure, I just was really glad to be invited on here, and hope to continue the dialogue. Nice to hear the different things that have been tried in different states, and we know, I know some of you here, and glad to see you, and the different partnerships that are developing. We know that we've got a long ways to go. We have some ideas. We think you'll have more about some things that will work, and have really appreciated bringing in that knowledge around the trauma-informed care, which is a little bit late for, I think, our field for a variety of reasons. And I think one of our barriers and opportunities is that it's making everything equal. Sometimes I think that we in DD, we might have moved away from some of the medical pieces because people didn't want to, and I see nodding, people didn't want to see people with developmental disability as being medicalized. And then we probably swung too far, right? In all that, but thinking about community, knowing that we needed to have the clinicians, we needed to have those supports. And so that's being welcomed. And then what's going to be that fine balance? Because we do believe that there are so many people that don't need some of the credentials on the home community-based side, that somebody may not need to be a BCBA. They could be somebody with great experience that people would review and say, yeah, they've got it, along with the professionals we have on the line here. And we think it's going to take everybody together. Every state's different, but we're really excited about the notion that if we could break down some of the vernacular, which gets everybody immediately saying, well, that doesn't going to work, and look toward what we know is the common cause, that we collectively believe that we're going to be able to come up with a number of the best practices we already see in states and build those out. As the Block Grant funding comes out, as some of the ARPA funding comes out, we really look to you as we beef up our promising practices and create more together. So thank you.
Terrific, Barbara. Thank you. And so we're at time. Dr. McKeon, can you bring us home? We've had some great stuff today with the team. We've got Jess Stolman-Rainey this coming week, Steve Hammerdinger, and then the special NASDDDS meeting on September 15th. Dr. McKeon, are you still with us or did you have to run? Brian, you want to make a final comment?
Yeah, I would just say, David, it's been a great discussion. And I think that I want to highlight one of the things that Mary said, that often the difficulty we have with the different populations is that it's communication. And sometimes if we just take a few minutes to try and better understand each other, it saves a lot of time in the long run. I spent a lot of time in the emergency room trying to convince people that taking somebody with a developmental disability was the right thing to do. It just takes a lot of time. And I think that that's a good area to underline. So thank you. Great discussion. Nice job, David.
Great. Thank you, Mary and team. And we'll look forward to seeing you all next week. And again, we're meeting with Brian tomorrow, Brian, about that special meeting, highlighting the top emergency department utilization nationwide. It's going to be revealing about some metro versus rural ideas that we've got. We want your ideas and look forward to seeing you next week. Take care.